Hi, I'm Dr. Ben Weinberg with the Ruch Center at Georgetown University, highlighting this week's paper, which is a randomized phase 2/3 trial comparing hepatectomy followed by FOLFOX with hepatectomy alone for liver metastasis from colorectal cancer. These are the long-term results of a Japanese study, the JCOG 0603 study. For folks with metastatic, or for folks with stage 3 colon cancer after surgery, we tend to recommend chemotherapy for all fit patients. So we would then hypothesize, well, for stage 4, people who are undergoing liver metastasis, they should get chemo as well. But that conventional wisdom has been challenged by the conduct of this trial. In this trial, 300 patients were randomly assigned, 149 to surgery alone, 151 to chemotherapy. You can see some patients were dropped due to ineligibility. And in terms of people who completed protocol treatment, only 91 in the chemo arm versus all 149 in the surgery alone arm. And then you can see at the bottom, there were 300 patients still included in the intent to treat analysis. Important to note that patients who had never had chemo before were also eligible, as were patients who had had prior chemotherapy. And you can see on the left side is randomized patients. On the right side are the so-called eligible patients. And you can see that the overall survival curves overlap essentially completely. And this is now with long-term follow-up, 7-year overall survival follow-up in the sort of 70% range for both arms. This is despite an improvement in disease-free survival with chemotherapy. So with chemotherapy, you can see longer disease-free survival in both groups. However, this disease-free survival benefit does not seem to correlate with an overall survival benefit, suggesting that we are delaying the appearance of recurrent or metastatic disease, but not moving the needle in terms of overall survival. And you can see that this is driven both on the disease-free survival forest plot on top and overall survival on the bottom, mostly by patients with left-sided primary tumors that were synchronous, meaning they were found at the time of the initial colorectal cancer diagnosis and who had not had prior chemotherapy. So this group seems to be dragging up, improving the disease-free survival. So again, if you have patients who are newly diagnosed, left-sided, no prior chemo, this is maybe a group to consider, giving chemo after liver resection. But again, this still did not translate into an overall survival benefit. But again, reading between the tea leaves, this is probably the patient population that derives the most benefit. So in summary, this really helps support that we don't necessarily need to be giving chemotherapy for folks with liver resections, even those who haven't received prior chemotherapy, although we will often still do that. Again, because the disease-free survival benefit did not seem to correlate with an overall survival benefit. This is a ripe space to use circulating tumor DNA. So post-operatively, if someone has positive circulating tumor DNA, I think we would still be justified using chemotherapy in those patients. Thanks for paying attention and hope this was helpful.